Yeah, okay. I think the audience also is able to see the slides. So, Dr. Dipesh, you can stop to share your screen, or you can stop sharing right now. So, whenever all of you are ready, you can let me know and we can start the meeting. I think it is still some time for 6 o'clock. 3 minutes to go. How many doctors are expected totally? Sorry, we can't hear you. Anand, have you muted them? Anand?
Hello, sir.
Yeah. Have you muted this 4 speakers because we can't hear them now?
No, I have not muted anybody.
Okay.
We got
Dr. Krishna was saying something, but we can't hear him.
Dr. Krishna. Can you hear us?
He can hear us, but he's speaking something, but we are not able to hear him. Even Dr. Ravindra is saying something, we can't hear him.
Microphone off. Microphone.
Is the microphone on with all of you?
Yes, my microphone is on.
Yeah, I can hear you.
Okay.
Dr. Dipesh and Dr. Vikram, your
I think mine is also on.
Yeah, correct.
Yeah, I'm Dr. Dipesh.
Yeah, I can hear you.
Okay, thank you.
I can hear you. I can hear Dr.
Okay,
Krishna.
can you hear me?
Yes, I can hear Dr.
Okay.
Krishna also.
I can hear
Dr.
you.
Vikram, can you say something?
Yeah.
Dr.
Yeah,
Vikram,
you
can you
just
say
spoke.
something?
I think we can hear you.
I can hear now.
Dr. Bikram.
Okay, we can hear him also. And Dr. Ravindra, can you say something?
Ravindra sir.
No, we can't hear you.
Yeah, Dr. Ravindra, we can't.
You have to put the microphone on or put on the headphones if you're on a laptop.
Okay. Can you hear me now?
Yes, I can.
Dr. Bikram.
Yeah.
Are you from mobile, tablet or mobile?
He's on iPad.
iPad. So just rotate the iPad because it's looking upside down in our webinars.
Yeah.
No, it is only for Dr. Bikram.
Just rotate it 180 degrees.
Is it okay now?
No, it's not okay now.
But Anand, I can see him straight. That's not a problem.
Because in my mobile and one of my desktop is in upside down. If everybody can see it, it's okay.
Is it okay now?
It's not okay yet. I don't know why.
No. So I think it's okay here.
Okay, no problem. No.
Okay. So, Dr. Krishna, over to you. You can start whenever you want.
Yeah.
Yeah,
I think Dr. Ravindra will start first.
Okay, shall I start? Are you all ready?
Yes.
I think is the time 6? Yes.
Yes.
Yeah, I think we can start now.
Yeah, sure.
Okay. Good evening, everybody. and welcome to this first webinar in neurology from Nepal. Uh, our session will be on thrombolytic therapy in ischemic stroke. As you know, that stroke is a huge burden in the world, and 15 million people suffer from stroke every year, and one third of them die, and the other third remains with some medical disability. And as you know, thrombolytic therapy in many trials have shown to be beneficial both in decreasing mortality and morbidity. So our this session shall be on thrombolytic therapy in ischemic stroke. The first speaker is Dr. Dipesh Sakia, who is an assistant professor in neurology in Kathmandu Medical College. We shall be speaking on in acute management and complication in ischemic stroke. Our aim of this webinar is mainly directed towards internists and residents in internal medicine, and this is mainly to encourage them and boost their confidence in using this thermolytic therapy in ischemic stroke. So, without much ado, I hand over to our speaker, Dr. Dipesh. Dr. Dipesh,
I
Yes.
think you can share your slide, Dr. Dipesh.
Yeah, I'm doing that.
Dr. Dipesh, you can share your slides and start.
Yes, sir. We're trying this. Uh,
There's an icon of sharing on your left.
yes, sir.
Yeah, you just tried sharing your slides, right?
Yeah. But the application window isn't showing anything here.
There are three dots,
Yeah, I
three
did that.
dots. Just
No, you'll have to put the presentation on first and then try this.
Okay. Presentation is on. Okay. Uh,
Just to remind everybody that this session will be
yes.
chaired by me. I'm Dr. Ravindra, and my co-chair is Dr. Bikram Gadre, who is an associate professor in neurology from the Institute of Medicine. He shall be chairing the next session. Next with the next speaker, Dr. Krishna Nana. So, Dr. Dipesh now, please.
Okay. Good evening, everyone. It is very delightful to have you all in this program, which is organized by National Neurology Association of Nepal. And I am Dr. Dipesh Saki, Assistant Professor in Neurology Department. The topic that I have is thrombolysis in stroke. So we'll start with the definition, the background. Stroke is a rapidly developing clinical sign of focal disturbance of cerebral function, lasting more than 24 hours or leading to death with no apparent cause other than that of the vascular origin. In simple form, we can tell it's a neurological deficit secondary to the vascular insult. So this is a definition. So generally, we divide the stroke into two types. That is the ischemic stroke and hemorrhagic stroke. Ischemic stroke accounts for 85% of the cases and hemorrhagic about 15% of cases. This is basic. So epidemiology, WHO, according to WHO, there are 15 million people suffering from stroke worldwide each year. Of these, 5 million people die and another 5 million people permanently disabled. So, on note that stroke is the second most common cause of death in the world after coronary artery disease. You can see this among the top 10 global cause of death in 2016. Stroke claims more than 5 million people of death. So it is the burden in the whole world population, the stroke, which is being a non-communicable disease. on this is the data, US data. On average, someone in the US has a stroke every 40 seconds. So while we are taking a class of about few minutes, there are about few cases in the US as per this data. On average, someone dies of stroke every 4 minutes. We have a very limited data of Nepal. Jaya Stroke Foundation had earlier estimated that 50,000 people suffer from the stroke every year in Nepal, and 15,000 people die of stroke annually. So the few studies are only done, and the most reliable, I think, this is the one which is done in 2006. So now we are talking about thrombolysis. Why thrombolysis or reperfusion therapy is important? We can see over here the picture. There is a dark black circle. This is the area of the brain which is destined to die. This is a ischemic core. This is not reversible. This is irreversible. But talking about the gray area of the brain, this is the area where there is a decreased perfusion of blood in this area. If we can reperfuse, if we can thrombolyze and increase the circulation in this area, we can save the part. This is known as penumbra, and this is a salvageable brain area. Hence, the reperfusion offers the potential to reduce the extent of ischemic brain injury and thus reverse neurological impairment. So, the treatment to time is very important in this. So, by this time, we know time is brain. So, in this chart, we can see that per stroke, a person is going to lose more than 1.2 billion of neurons, and more than 7,000 myelinated fibers are lost. And the age is accelerated by 36 years. See the per stroke, talking about per second, the patient is going to lose more than 32,000 neuronal loss, more than 230 million synapses loss, more than 200 meters of myelinated loss, and the patient age per second accelerates by 8.7 hours. So we can see the burden of the disease according to the time. So time is very important for the treatment of the stroke patient. So having said that, average time of the presentation after the stroke in Nepal is 28 hours. Generally, people present to us after a day or two. Only 16.5% of the patient presents within 4.5 hours. See, we have a very narrow therapeutic window, and we get less amount of people in in our hospital. This was a study done in teaching hospital. Now we'll talk about the thrombolysis in stroke. We got into the thrombolytic proper. So NIH recommends that door to needle time has to be less than 60 minutes. Door to needle time is the time when the patient arrives to the hospital till the patient receives the IV thrombolytic therapy. This is the golden hour for evaluating and treating the acute stroke. We can see this chart where time zero is the patient when reaches to the hospital in the emergency department. Less than 10 minutes, the patient should be evaluated, done the lab works, history, and the stroke team should be activated by then. Less than 25 minutes, the CT scan should be initiated, and less than 45 minutes, CT scan and lab interpreted. Less than 60 minutes, RTP therapy should be started. So this is the door to needle time for a developing country like us. We have a limited resource and manpower, but in the developing countries, they are still practicing the door to needle time is less than 30 minutes. It is a standard for developed countries. They do the door to needle time within 10 minutes. The case is evaluated by the stroke team, and all the investigation are sent. Within 20 minutes, the CT scan should be initiated, interpreted, and 30 minutes, the thrombolytics should be started. We should always target as early as possible, less than 30 minutes or more before 60 minutes, because time is very important for the treatment. For each 15 minutes, the reduction in time for the treatment of thrombolytic, we improve the patient mortality by 4%. We improve the patient complication of intracerebral hemorrhage by 4%. So the each minute is very important. You know that 1.9 millions of neurons are lost in 1 minute. So door to needle time should be minimized as possible. So now in the first 10 minutes, the assessment goals includes assess ABC, airway, breathing, circulation. The patient may require ventilator in case of severe stroke or when there is a bulbar involvement, bulbar stroke. And vital signs should be monitored, including blood pressure, temperature, respiratory rate, pulse. Provide oxygen by the nasal cannula. Mark all patients may not require the oxygen therapy. We should aim to make the saturation more than 94%, and those people may require the oxygen therapy. Obtain two large bore IV access. Obtain blood sample, including CBC, electrolytes, troponin I, because most of the time the stroke patient may have a coexisting MI. Coagulation studies, including PTINR, APTT, this platelets. Obtain 12 lead ECG, because arterial fibrillation is common among the stroke and they have to be monitored as well. Check blood sugar. Treat if indicated. The very easily investigation that will be done, and the only required for the thrombolytic therapy, the investigation is blood sugar. We can do the blood prick test and treat if it is necessary. The patient should be kept in the supine position in non-hypoxic patient. In the supine position, the patient cerebral perfusion is maximized, but make sure the patient doesn't have is not toxic, is not unconscious. There's no symptoms of increased ICP. This should be considered during the patient when kept in supine position. By this time, 10 minutes, alert stroke team, neurologists, radiologists, CT technicians should be alert. Perform a neurological screening test, that is GCS, NIHS score, and a routine neurological examination. By this time, by 10 minutes, we should order a CT scan brain without contrast. So talking about NIHS scale, it's a National Institute Health Stroke Scale. Why do we do it? It is a standardized stroke scale severity. What it does is quantify our clinical examination in terms of numbers that will help us to communicate between the doctors. We tell them this is the NIH score. It also tells that whether the patient is neurological improving or deteriorating. Deteriorating when deteriorating, is there any problem? Am I audible?
Yeah, yeah.
Yeah.
Okay, okay. Determine the patient neurological. It NIHS also score helps in determining the patient neurological status, and it also helps us to know that whether this is a high risk thrombolytic therapy or not. Otherwise, if there is more than 25 of NIHS scores, then we tell it's a high risk thrombolytic therapy. So, what is NIHS score? It consists of a neurological examination parameters that are high mental function, cranial lobe examination, cerebral examination, motor examination, sensory examination, language, and cortical examination. These each and every parameters are given a score from 1 to 3, and we all take this in numbers and we tell the severity of the stroke disease. If it's between 0 to 4, we call it mild. If it is between 5 to 15, we call it moderate. If it's more than 15, then we call a severe stroke. So this is a chart which we can carry out with our stroke protocol, as well as we can have this in a mobile app as well. So this NIHS score, so I will not be able to make you understand about the NIHS score assessment. However, I'm going to give you a link which is very nice and very nicely explained. Explained. You can check this site and you get it in the YouTube. And this examination is followed by most of the neurologists. So please, you can write it down. Okay. Within the time goal of 25 minutes, immediate neurological assessment by the stroke team should be done, and less than 25 minutes to 45 minutes, the CT reporting should be done. It has to be known that the patient reporting, is it hemorrhagic or ischemic. So non-contrast CT scan of brain is more than enough for early diagnosis of stroke. It is the initial imaging modality in hyperacute stroke. Maybe in hyperacute stroke, the CT scan may be normal, but by the clinical judgment, by the sign and symptoms, we do the diagnosis clinically. CT scan is widely available, quick, easy to perform. It accurately identifies hemorrhagic versus ischemic. So intracranial hemorrhage or subarachnoid hemorrhage can be distinguished by this modality of imaging. MRI can be also done, but if it takes time to do it, we are not doing MRI. We will be happy with the CT scan, non-contrast, and we go for thrombolytic therapy. But however, MRI can be done, easily available. It can detect as early as 39 minutes of stroke. DWI and ADC sequence can detect an early infarction. This is a DWI where you can see the hyperintensive lesion, and corresponding ADC, there is a black lesion. It can catch early as 39 minutes of stroke. The other is CT angiography of head and neck. It should be done in all the patient with ischemic stroke, but we should not waste our time doing CT angio along with CT plane. First, do the CT plane, see the lesion. If the patient is eligible for thrombolytic, do thrombolytic, then go for CT angio. CT angio helps to detect the intracranial large vessel stenosis and occlusion with high accuracy, which may be resistant to thrombolytic therapy and helps triaging for mechanical thromboectomy. If there is a large vessel occlusion, these are less responsive to thrombolytic therapy. So the patient thrombolized who have been thrombolized may go to thrombectomy therapy later on, and which will be helpful by doing CT angiography. So within the time goal of 45 minutes, treatment decision should be done by the specialist. By this time, indication and contradiction of the thing thrombolysis should be sorted out. This will be done by Dr. Krishna. Repeat neurological examination should be done whether the patient is high risk thrombolysis, or patient is the fate. What is the fate of thrombolysis? We can know by the NIH score as well. So blood pressure management, the very important is high blood pressure. Before commencement of LTPs, we should have a target blood range below systolic blood pressure 185 and diastolic pressure 110. If it's more than this, we use a laboratory injection 10 to 20 mg IV over 1 to 2 minutes, followed by an infusion at 2 to 8 mg per minute, not to exceed 300 mg per day. Nicardipine infusion 5 mg per hour, titrate up to 2.5 mg per hour at 5 to 15 minutes interval. Maximum dose is 15 mg. Other drugs that can be used is enalaprate, hydralazine. If the BP is not controlled with this, then we can add sodium nitroprusside. So you should be careful with sodium nitroprusside because it has a theoretical risk of increasing the intracranial pressure. So if the diastolic blood pressure is still 140 mmHg, then we use sodium nitroprusside with a time goal of 60 minutes. Now, by this time, we should have started intravenous LTPase administration. For these, two wild boar cannula has to be placed in the brachial veil, preferably. Body weight should be determined. The dose of LTPase is calculated at 0.9 mg per kg of the body weight. It should not be given more than 90 mg. 10% of the dose is given as an intravenous bolus over 1 minute, and the remainder is infused over 1 hour. So this is the protocol. So what are the things you should monitor during and after the thrombolytic therapy? Vital signs, again, such as BP, temperature, pulse, respiratory rate, neurological status, NIH score, pupil, GCS, hand grip, sensory finding, all should be checked every 15 minutes during and for 2 hours after the LTPase treatment, then every 30 minutes for 6 hours, then hourly for 24 hours from the start of the LTPase treatment. So these are things that to be monitored. Blood pressure should be maintained at or below 180 by 105 mmHg during the first 24 hours. If not be able to control, start the antihypertensive in infusion as we discussed before. A follow-up non-contrast CT scan should be done 24 hours later and before starting the treatment of antiplatelet anticoagulant agent. So CT scan should be done 24 hours of the treatment. Things to be avoided. So what things are to we should avoid is anticoagulant, antiplatelet, maybe warfarin, heparin, aspirin should be avoided for at least 24 hours. Intra-arterial catheters, indwelling bladder catheter, nasogastric tubes should be avoided at least for 24 hours unless very necessary. If it's necessary for catheterization, we can do only after 1.5 hours post-thrombolytic. Avoid IM injection for 24 hours. Avoid vein puncture for 12 hours. Avoid suction whenever possible. Caution when giving mouth care. So these are things you should avoid and should be careful of. So when to stop the RTP infusion? If there is anaphylaxis, generally orolingual edema, sometimes it's mild form, it's sometimes very severe form. BP systolic less than 100 mmHg, sustained BP rise to more than 180 by 105 mmHg for 5 minutes even after treatment, associated with neurological deterioration of any sort. Major systemic bleeding, generally gastrointestinal or genitourinary severe bleeding. Otherwise, minor bleeding, oozing blood from the vein or catheter site is not a indication to stop LTPs. If there is a neurological deterioration of GCS more than 2, the GCS decrease more than 2, then we consider as a neurological deterioration and we need to stop RTPA. So indication for urgent CT scan, when we do a urgent CT scan, when there is a sign and symptoms of intracerebral hemorrhage, one of the very dreadful complication is intracerebral hemorrhage. And when we feel the sign and symptoms of intracerebral hemorrhage or raise ICP, then we start to a urgent CT scan. New or worsening severe headache, The symptoms are acute hypertension, nausea, vomiting, agitation, seizure, a neurological deterioration of GCS by 2 points, NIHS increased by 4 points, or new neurological deficit contralateral to the stroke. So now we come to the complication. Generally, the RTPA has a complication, few complication. A very dreadful and fearful complication is the intracranial bleeding. Intracranial bleeding presents with clinically two types. We have symptomatic intracranial bleeding, which occurs in about 6%, and fatal intracranial hemorrhage, which occurs in 2.8%. So this is a CT scan of a patient, our patient. We did a thrombolyte in this. It's a 65 years male who presented to KMCTS with NIHS score of 19, and the patient has a history of stroke 1 year back, and we did the thrombolytic therapy, and unluckily the patient had this severe interparenchymal hemorrhage. The patient landed up being fatal intracranial hemorrhage. We tried treating the patient, but we could not revive the patient. The patient expired, and the intracranial hemorrhage was seen after 5 hours of RTPA. So now we talk about the management of symptomatic intracranial bleeding. So stop antiplatelet infusion at once. We send a blood investigation, CBC, PTINR, fibrinogen level, cross match, blood group type, coagulation studies. Urgent non-enhanced CT scan should be done. Cryoprecipitate, 10 units, infuse over 10 to 30 minutes. Additional dose should be given to maintain the fibrinogen level below 150 to 200 mg. Generally, in our context, we don't get cryoprecipitate that easily. Actually, cryoprecipitate is the concentrate form of fresh frozen plasma, which is rich in factor 8. So what we do in our context is we don't get cryoprecipitate. We have arranged a fresh frozen plasma in pins. So generally, a patient may require fresh frozen plasma 15 ml per kg. This can be stored up to 6 months. Third, and we use it. We have prepared fresh frozen plasma at least 10 units in our system, and if the patient has bleeding, we can't get cryoprecipitate, we use fresh frozen plasma 15 ml per kg, and we give a platelets of 6 to 8 units irrespective of the platelet count. If the platelet count is less than 1 lakh, we should give 6 to 8 units. But even though if the platelets count is also normal, we have a symptomatic hemorrhage, we give this platelets not for the platelets thrombocytopenia, but we give for the platelet dysfunction. The antifibrinolytic agent can also be used. We used tranexamic acid 1 gram IV bolus over 10 minutes, followed by 1 gram IV over 30 minutes. Or we can also use another antifibrinolytic agent, such as, which is not that commonly found, aminocaproic acid 4 to 5 gram IV during first hour, followed by 1 gram per hour for 8 hours until bleeding control. So we generally go with the tranexamic acid, but if we have this, it's good as well. Hematological and neurological consultation should be done. Supportive therapy, including BP management, ICP, mean arterial pressure, temperature, and glucose control should be done along with the other treatment. Now, the second complication is orolingual angioedema. It occurs in about 1 to 8%. Most of the time, it is transient and mild, but rarely it is severe. So what we do that time, we discontinue IV ATPase infusion and hold ACI. Most of the time, orolingual edema is seen with the patient with ACI, taking ACI. So we need to stop ACI. Give IV methylprednisolone 125 mg stat or injection hydrocortisone 200 mg IV stat. Give IV diphenhydramine. This is the antihistamine. Give ranitidine 50 mg IV or famotidine 20 mg IV. If the further does not improve and increase the angioedema, we give adrenaline 500 microunit IM. So talking about orolingual angioedema, the dreadful complication is when there is an airway compromise. Whenever there is edema limited to anterior tongue and lips, intubation is not necessary. But when there is a rapidly progressive airway compromise, generally within 30 minutes, that poses risks for requiring intubation. What we do, the very good protocol is awake fiber optic intubation. This is optimal. In this, the patient is not paralyzed or not fully sedated. Mild sedation is given with local anesthetic, and there is a direct visualization of the tract, and there with the guidance of the scope we did the intubation. Hence, the bleeding complication is low and easy. This has to be done with a very specialized team. Now we talk about outcome. For every, you can see this chart, there's 100 people. For every 100 people over here, They treated with TPA 32 patient benefits. These are the 32 patients who benefited, and 3 patients are harmed. Among these 32 patients, 13 patients, which is a dark green, 32 patients are normal or near normal, and the remaining are doing really good. And these are the white patients, which are colored white. They didn't show any better. Among these 3 people who are the worst situation, among one will die or have severe disabled, and 2 of them have a severe complication. So looking on to this, and the disability that the patient will have, doing thrombolytic is very justified. So other IV thrombolytics, apart from alteplase and tenecteplase, the benefit of other fibrinolytic agent is not proven. So hence it is not recommended. So alteplase, tenecteplase can be used. Tenecteplase can be used alternatively. Tenecteplase administered at the dose of 0.2 mg per kg single dose IV bolus, not to exceed 25 mg. It has a similar safety profile, but has not proven to be superior or non-inferior to alteplase. So it is unclear whether it is effective as alteplase or not. So still, when we can't find alteplase, we use tenecteplase. So take-home message: time is brain, time saved is brain saved. Reperfusion as quickly as possible to save the penumbra. The thrombolytic should be given within the narrow period of time, that is 4.5 hours. The benefit of treatment decreases continuously over time. Unnecessary wastage of time should be avoided. Even if we give a thrombolytic therapy and the patient is patient shows we do a CT angiography and the patient shows a last visual occlusion, we plan it for thrombectomy. We will not wait for the improvement for thrombolytic therapy post thrombolysis in a patient. We take the patient direct to thrombectomy without wasting our time. So there is no place for wasting of time in case of ischemic stroke. The chance for good outcome decrease progressively with time. So time is brain. I think we have to. Another thing is we have to create awareness about this to all the people, our patient. The time is brain. The term the patient uses heart attack. Similarly, this is a brain attack. We have to make them understand the severity of disease, the burden of the disease, the depression, the psychological burden, the financial burden to the patient party. So I think this completes my lectures, and I would like to thank you all on behalf of my department, Neurology, Kathmandu Medical College Teaching Hospital, and from National Neurology Association. Thank you very much. Hello. 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 Hello.
Anand here. Can you hear me? So switch on the left side. Switch on your speaker on the left
Yeah.
side of.
Okay.
Yeah.
Yes. Right.
Yeah.
Can
Can
you?
you hear me?
I finished my lecture. Yes.
Dr. Dipesh,
Yes, sir.
thank you. Thank you for your very comprehensive review on management of thrombolysis therapy in ischemic stroke and its complications. I
Yes, sir.
think of all the challenges, one of the most challenging aspects of managing ischemic stroke is time constraint. Because the window period is so narrow, 4.5 hours only, we must be ready to manage the patient within 1 hour. That means door to needle time should not exceed 1 hour. So if we can do that, I think we can go a long way, and the benefit still outweighs the complication. So
Yes.
the next part of the session, I have to ask Dr. Vikram Gazulal to take over and chair this session. Dr. Vikram, please. Dr. Bikram?
Dr. Bikram,
He's trying to say something, but we are not able to hear him, I think. Dr. Bikram, can you put on your microphone, please? Alan, can you check if Dr. Bikram's mic is muted?
If you first, I'm switching off and doing it on again.
Yeah, Dr. Bikram is the one who's sitting with the green background.
Yes,
Hello,
sir.
Dr. Bikram?
Can you hear me, Bikram? Dr. Bikram?
Audio on गर्नुहोस् त एक्चुअली on एक्चुअली फेरि अफ गरेर फेरि on गर्नुहोस् त ए Dr. Bikram says that maybe it's in the center, from your center, that the mic has been turned off.
No, it is on. I can see that.
Dr. Bikram, is on. Can you turn it off and on again?
hello?
Yeah,
So
Dr.
there should
Krishna,
be.
we can hear you. It's just
Yeah.
just give us a minute because Dr. Bikram is not able to speak anything.
Yeah.
For the audience, you can be ready with the questions. We'll have the question and answer section after Dr. Krishna's presentation. So in the meantime, we're trying to get back Dr. Bikram's audio. तपाईँको आएन Dr. Bikram audio आएन. The connection has been lost. Can you do something from the center, please? Okay. Dr. Krishna, can you hear me?
Yeah, I am here, sir. Yeah. Yes.
Shall I go on? I'll ask Dr. Bikram to join us at the end of the session.
I think that will be okay.
Dr. Krishna is the next speaker. We're sorry Dr. Bikram could not join because of some technical error. Dr. Krishna Dungana is DM in neurology and is an associate professor in the Department of Neurology in Kathmandu Medical College. So he shall be speaking on indication and contraindication of thrombolysis, thrombolytic therapy. So without much ado, I'll hand over the session, the floor to Dr. Krishna, please. Dr. Krishna, you can start now. Dr. Krishna?
Shall I start?
Yeah, please start. Please start.
Good evening, everyone. So it is delightful for us to have you all here for this webinar, which we are doing. So I'll be mainly talking about the recommendation part. I'll be talking about the recommendation for the intravenous thrombolysis in acute ischemic stroke, and I'll be talking about the indications and the contraindications. And as Dr. Ravindra has said, I think you can type your question in the question section. So we'll have a question answer session at the end of this session. So in my presentation, I'll be talking about the class of recommendation. So there is class of recommendation 1, 2A, 2B, and 3. So what is class of recommendation 1? Class of recommendation 1 says that the benefit is more than the risk. Benefit is very much more than the risk, and the procedure or treatment should be performed or administered. Another is class of recommendation 2A. So this says that the benefit is still greater than the risks, and but additional studies with focused objectives are needed, and the procedure or treatment is reasonable. Another is class of recommendation 2B. In this, the benefit is slightly greater than the risks, or sometimes it is equal to the risks. Additional studies with broad objectives are needed, and additional registry data will be helpful. And procedure or treatment may be considered. Another is class of recommendation 3, in which the treatment has no proven benefit and it is not helpful. Class 3 also includes harm, that is, it says that the treatment has excess cost without benefit, or is harmful, and the treatment is harmful to patients. So now we'll be talking about the different recommendations. So first we'll be discussing about the age. So for which age we can give thrombolytic therapy? Can we give that to all age group, or we can give to selected age group? So there is a class 1 level of recommendation that we can give to all age groups equal to or more than 18 years of age if the patient comes within 3 hours. So it is equally recommended for patients who are less than 80 and more than 80 years of age. Though we know that older age is an adverse prognostic factor in stroke, but that does not modify the treatment effect of thrombolysis. That is, thrombolysis works equally in age group less than 80, more than 80, more than 18 years of age. But we also know that older patients have poorer outcome, higher mortality, and higher rates of symptomatic intracranial hemorrhage than those less than 80 years of age. So that was the class 1 recommendation. So class 2B recommendation says that in pediatric age group, the efficacy and risks of giving this IV thrombolysis is not well established. That is, in neonates, children, adolescents less than 18 years of age, IV thrombolysis efficacy and risks is not well established. There are different studies, and there are very few case studies in which they have done thrombolysis in this age group also. But for that, you have to confirm that it is stroke. You have to do MRI along with MRA, MRV, etc. So another is the stroke severity. So can we give IV thrombolysis to all patients with all degree of grade stroke severity? So the class 1 recommendation says that we can give thrombolysis even to patient with severe strokes if the patient comes within 3 hours. Though we know there is increased risk of hemorrhagic transformation in this age group, but still there is proven clinical benefit for patients with severe stroke symptoms. Another definitions for mild and disabling stroke, and this is in this group also, if the patient comes within 3 hours of symptom onset, then there is class 1 level of recommendation for giving IV thrombolysis. So what are mild but disabling stroke? So mild and disabling stroke means if there is complete hemianopia with a score of 2 or more than 2 on NIHS question 3. Another is severe aphasia. That is, if there is severe aphasia and the score is 2 or more than 2 on NIHS question 9. Or if there is visual or sensory extinction, that is the score is 1 or more than 1 on NIHS question 11, or any weakness limiting sustained effort against gravity. That is, the NHS score is 2 or more than 2 on NHS question 5 or 6. And lastly, if the treating practitioner along with the patient thinks that the deficit is potentially disabling using clinical judgment, then that is also said to be mild disabling stroke. So if the patient has mild disabling stroke and if patient comes within 3 hours, then that is a class 1 level of recommendation for giving IV thrombolysis. Another is if the patient has mild stroke, that is NIH score is 0 to 5, but if the score is not disabling, then in this case, there is no benefit of giving IV thrombolysis, and IV thrombolysis is not recommended for patients in this category, though it can be treated within the 3 hour or 3 to 4.5 hours time range. Early improvement. So if a patient presents with moderate to severe ischemic stroke, but when you saw the patient has early improvement, has shown some improvement, then you have to decide if the patient is still moderately ischemic and IV thrombolysis, it is reasonable to give that, and there is a class 2A recommendation. Timing from stroke onset. So all of us know that for thrombolysis, for giving thrombolysis up to 3 hours, there is class of recommendation one if other eligible criteria are met. But if the patient comes in the time window of 3 to 4.5 hours, then there is only class 1 recommendation if the age group is less than or equal to 80 years, if the NIHS score is less than or equal to 25, if the patient does not have a history of diabetes or prior stroke, if the patient is not taking oral anticoagulants, if there is no imaging evidence of ischemic injury involving more than 1/3 of the MCA territory. So this is a class of recommendation 1 in the 3 to 4.5 hour window. Another is urgency, as shown by Dr. Deepesh previously. So with each minute, each second, each hour loss, there is more damage to the brain tissue. So treatments will be initiated as quickly as possible, and time to treatment is strongly associated with outcome. So in this slide, we can see two categories of patient. In the first group, the thrombolysis is done within 3 hours, and in the second group, the thrombolysis is done in the time range of 3 to 4.5 hours. And we can see that in the first group, 32 patients are benefited, and in the second group, only 16 patients are benefited. So from this slide also, we can say that we should do thrombolysis urgently. We should not waste time. Now, if the patient has come in the time of 3 to 4.5 hours, and if the patient is more than 80 years of age, still we can go ahead with thrombolysis. It is safe and as effective as in the younger patient, but the class of recommendation is class 2A in this. If a patient has history of diabetes mellitus with previous stroke and patient comes within the time range of 3 to 4.5 hours, then thrombolysis may be as effective as in the 0 to 3 hour time window, and it may be a reasonable option, and the class of recommendation for this is 2B. Another is if the patient comes with mild disabling symptoms, stroke, as we have discussed previously in the 3 to 4.5 hours range, still in this case, we can go ahead with thrombolysis, and the class of recommendation is 2B. Another is if the patient comes in the time range of 3 to 4.5 hours, and if the patient has a severe stroke, in this case, the benefit of this thrombolysis is uncertain if the patient has an NIHS score more than 25, because the patient with thrombolysis also will not be doing very good. Wake up and unknown time of stroke. So this has come with the wake up trial, which has come recently, and this says that if a patient wakes up with stroke, previously we used to take the time when the patient went to sleep as the time the patient was last normal, and we used to calculate the time according to that. But nowadays we see that if the patient MRI can be done, we do the MRI, and if we see that in the MRI the flare is negative, and if the DWI is positive, then that means that patient had stroke less than 4.5 hours old. And if the DWI includes less than one third of the MCA territory, then thrombolysis can be beneficial, and we can go ahead with thrombolysis. In this case, the class of recommendation is 2A. So now we'll talk about some conditions related to bleeding. So if there is an intracranial hemorrhage, then we don't administer uh, IV thrombolysis. If there is a history of intracranial hemorrhage also, we don't administer IV thrombolysis. Sometimes patient may come with a strong history of subarachnoid hemorrhage, which may be missed in some CT scan also. So if you are suspecting a patient is having subarachnoid hemorrhage, then you should not thrombolyze that patient. Menstruation. So patient female may be menstruating when they land off with an acute ischemic stroke. Then in that case also you can go ahead with thrombolysis if there is no history of menorrhagia. And the class of recommendation is 2A, but you should say to the patient that there may be increased risks of bleeding before that. Another is if a patient has a recent or active history of menorrhagia, but there is no clinically significant anemia or hypotension, still you can consider thrombolysis, IV thrombolysis. The class of recommendation is 2B. And if there is menorrhagia with anemia, then you have to consult with the gynecologist before going ahead with thrombolysis if you want to give that. Regarding the pregnancy and the postpartum, in pregnancy also you may uh, consider thrombolysis, but you have to balance the risks and the benefit, because if you think that the anticipated risks benefit is more of treating the moderate or severe stroke than the risks of uterine bleeding, then you can go ahead with thrombolysis. This is a 2B class of recommendation. And in the postpartum period, the safety and efficacy has not been well established regarding this IV thrombolysis. Coagulopathy. So when a patient comes to you with acute ischemic stroke, the patient is not on anticoagulants, the patient is not on, does not have any liver disease, then you can go ahead with thrombolysis. But you have to send this test, and if this test comes out to be positive, that is if the platelets is less than 1 lakh, if the INR is more than 1.7, if the APTT is more than 40 seconds, or if the PT is more than 15 seconds, then in this case the safety and efficacy are unknown, and IV alteplase should not be administered. This is the same thing I just said. Warfarin use. So if a patient is using warfarin, but you do the INR and PT, and the INR is less than or equal to 1.7, and the PT is less than 15 seconds, then in those cases also thrombolysis may be reasonable, but this is a recommendation is 2B. If a patient is on therapeutic doses of low molecular weight heparin, then you should not give IV thrombolysis in those patients because it causes harm in those patients. Another is drugs, that is these thrombin inhibitors or factor 8 inhibitors, 10 inhibitors like dabigatran, which has been commonly used nowadays. So if a patient is on those drugs and patient develops acute ischemic stroke, then in those patients thrombolysis has not been firmly established, and it may be harmful. So usually we don't give thrombolysis, but if we want to give thrombolysis, if it is a very large stroke, if we think it may be helpful, then we have to do the laboratory tests like APTT, INR, carrying clotting time, thrombin time, or direct factor activity assay, and see that it is normal. Or patients should have received the dose uh, before 48 hours, and the renal function should be normal. Or we can use some drugs to reverse the action of these as in thrombin inhibitors, and after that only we can go away with thrombolysis. If the patient is taking concomitant abciximab, and in those cases also you should not give IV thrombolysis. It causes harm. Prior antiplatelet therapy. So patients may be taking antiplatelet therapy, that is aspirin or clopidogrel, for some cardiac disease since long term, and if the patient develops acute ischemic stroke while the patient is taking those drugs, either in monotherapy or in combination therapy, you can still go ahead with thrombolysis. The class of recommendation is 1. Though there is a slightly increased risk of symptomatic intracranial hemorrhage, still you can go ahead with thrombolysis. End-stage renal disease, if the patient has end-stage renal disease and is on regular hemodialysis and has normal APTT, there is class 1 recommendation that you can go ahead with IV thrombolysis. Recent major trauma. Recent means within the last 2 weeks. So if a patient developed a recent major trauma within the last 2 weeks, excluding the head trauma, then in those cases you can consider giving thrombolysis. The class of recommendation is 2B, but you should see what is the risk of bleeding from injuries related to the trauma, and you should weigh that against the severity and potential disability from the ischemic stroke. Similarly, if there is recent major surgery within the last 2 weeks, then in this case also thrombolysis may be considered. The class of recommendation is 2B, and the potential increased risks of surgical site hemorrhage should be weighed against the anticipated benefits of reduced stroke-related neurological deficits. Severe head trauma within 3 months, in those cases, thrombolysis is contraindicated and it causes harm if you give thrombolysis. If a patient has acute head trauma and is admitted, and while the patient is admitted and patient develops ischemic stroke, in that case also it can cause harm. You should not give IV thrombolysis. If there is past gastrointestinal or genitourinary bleeding, then you can go ahead with thrombolysis. The class of recommendation is grade 2B. Because there is a low bleeding risk, you can go ahead with thrombolysis. So now I'll show one case which we had thrombolized. This was a 50-year-old patient who came within around 2 hours of ischemic stroke. And when we saw the patient has NHS score of around 20, and the patient did not have any movement of right side of the body when the patient came, and patient had severe dysarthria. His speech was not uh, understandable, and we did the thrombolysis, and this is the second video which shows that within around 20 minutes of thrombolysis, while we were still giving thrombolysis, the patient was able to move the right side of the body, which we can clearly see in the picture here, and patient speech also improved. So this was a very beautiful case, and this patient has a great improvement with giving IV thrombolysis. So this was one of the cases in which we did thrombolysis. So now coming to the cardiac condition. So we'll come to different cardiac condition, like first is the acute myocardial infarction. So patient may develop myocardial infarction and acute ischemic stroke at the same time. So what should we do in those cases? In those cases, what we do is we treat with IV alteplase at the dose appropriate for the cerebral ischemia. And after that, we go ahead with percutaneous coronary angioplasty and stenting if it is indicated. If the patient has a recent MI, that is, if the MI is within the last 3 months, then in those cases, thrombolysis is reasonable. That is, it has a class of recommendation 2A. If the recent MI was a non-ST elevation MI, or if the recent MI was a ST elevation MI involving the right or the inferior myocardium. That is a class 2A recommendation. And if the patient has a MI, ST elevation MI involving the left anterior myocardium, still in those cases also we may consider giving IV thrombolysis, and the class of recommendation in this is 2B, acute pericarditis. So if a patient has acute pericarditis, we should see whether there is a major acute ischemic stroke or a moderate acute ischemic stroke. So we should see whether there is severe disability or mild disability. So if there is a severe disability, giving thrombolysis may be reasonable. We should consult with our friend cardiologist, and we may go ahead with thrombolysis. But if there is only mild disability, then giving thrombolysis is of uncertain net benefit in these cases. Left atrial or ventricular thrombus. So in left atrial or ventricular thrombus, it is the similar case. So if there is major acute ischemic stroke causing severe disability, giving thrombolysis may be reasonable, and there is a class 2B recommendation. But if it is a moderate acute ischemic stroke, which is likely to produce mild disability, then IV thrombolysis has uncertain net benefit. Procedural stroke. So sometimes if some procedure is being done like cardiac catheterization, cerebral angiography, and during that time patients develop acute ischemic stroke, in that case also you can go ahead with thrombolysis, IV thrombolysis. It is reasonable, and the class of recommendation is 2A. Infective endocarditis. So there is an increased risk of intracranial hemorrhage in infective endocarditis. So if a patient with infective endocarditis develops acute ischemic stroke, then in those cases you should not give IV thrombolysis. In case of aortic dissection, aortic arc dissection, so in case of aortic arc dissection also, if a patient is known or suspected to have aortic arc dissection and develop acute ischemic stroke, you should not give IV thrombolysis. It is harmful in these cases. Blood pressure. So if the blood pressure is less than 100, can maintain their blood pressure maybe up to 24 hours with the antihypertensive medication, then patient can be given thrombolysis, and the class of recommendation is 1. So we have to take the previous history also while we go ahead with thrombolysis. So if a patient has ischemic stroke within the last 3 months, so in this case, giving IV thrombolysis may be harmful. So we may not give IV thrombolysis in these cases. History of intracranial hemorrhage, we don't give IV thrombolysis. If a patient has intracranial or intraspinal surgery within the last 3 months, then giving IV thrombolysis is potentially harmful. So we should not give IV thrombolysis if the patient has intracranial or intraspinal surgery within the last 3 months. Another is GI malignancy or GI bleed within the last 21 days. If a patient has structural GI malignancy, or if a patient has recent GI bleeding, then it should be considered high risk, and giving IV thrombolysis in these cases is potentially harmful. Atrial puncture. So sometimes while we are inserting CBP or we are doing other procedure like keeping pacemaker or other procedure, then we may accidentally puncture an artery like subclavian artery. So what should we do in those cases? If it is it has occurred in the last 7 days. And in those cases, the safety and efficacy of giving IVA thrombolysis is uncertain. Dural puncture. So in our neurology, we do lumbar puncture to diagnose different CNS infection. And if the lumbar puncture was done in the last 7 days, still if there is although there is an increased risk of epidural hematoma, we may still consider giving IV thrombolysis in these cases. The class of recommendation is 2B. Intracranial abnormalities. So nowadays we may be finding accidental aneurysm when you do some CT angiography. So what should we do if there is an intracranial aneurysm, which is unsecured and which is unruptured? So if it is a small or moderate size, in those cases, we can go ahead with IV thrombolysis. If the patient develops ischemic stroke, the class of recommendation is 2A. And if there is a giant aneurysm, then in those cases, the usefulness and risks of IV thrombolysis is not well established. Intracranial vascular malformation, AV malformation. So in this case also, the usefulness and risks of IV thrombolysis is not well established. The class of recommendation is 2B. So if you think that the stroke is very large, uh, which and the risks of that stroke is more than the risks of symptomatic intracranial hemorrhage, sometimes we may go ahead with intravenous thrombolysis also. About neoplasm, so there may be a extraaxial intracranial neoplasm or intraaxial intracranial neoplasm. So if it is an extraaxial intracranial neoplasm, it is probably recommended to give thrombolysis, and the class of recommendation is 2A. But if it is an intraaxial like glioma, then giving IV thrombolysis is potentially harmful and it may cause more harm. Blood sugar. So usually we give the class of recommendation is class 1 if the blood sugar is more than 50 milligram per deciliter. So if the blood sugar is less than 50 or more than 400, but these are normalized and still the deficit remains, that is the deficit is not due to hypoglycemia or hyperglycemia, it is due to stroke, then we can go ahead with thrombolysis, although the class of recommendation is 2B. CT findings. So we do CT and diagnose stroke. Sometimes CT may be normal. So if there is early ischemic changes on CT of mild to moderate extent, we can go ahead with thrombolysis. If there is no frank hypodensity, that is class of recommendation is 1. If there is an hypertense MCA sign, which is an early sign we see in stroke, giving IV thrombolysis is beneficial and class of recommendation is 2A. If there is extensive region of clear hypoattenuation, hypodensity in CT scan, then thrombolysis is not recommended because whether you give thrombolysis or not, the patient will not be doing better in these cases, and there is no benefit of giving IV thrombolysis. So some other conditions, extracranial cervical artery dissection. So we may have extracranial dissection or intracranial dissection. If there is an extracranial cervical arterial dissection, in those cases also it is reasonable and safe to give IV thrombolysis if the patient develops acute ischemic stroke. If there is an intracranial arterial dissection, then the usefulness and the risks of hemorrhage is not well established. So we may not give IV thrombolysis in these cases. Ophthalmological condition. So many patients with diabetes develop acute ischemic stroke and they may have diabetic retinopathy. So if a patient has a history of hemorrhagic diabetic retinopathy, still we can give IV thrombolysis. The class of recommendation is 2A because there is a very less risk of bleeding, but you must weigh against the potential increased risk of visual loss from the benefit. Seizure at the onset. So if a patient has seizure at the onset of acute ischemic stroke, still thrombolysis, IV thrombolysis is reasonable. If you think that the seizure is not part, the weakness is not part of the torus paralysis. pre-existing disability. In patient with pre-existing disability, like the MR modified ranking scale is 2 or more than 2, still you can go ahead with thrombolysis. The class of recommendation is 2B, but you have to take into account other factors like patient and family's preferences, social support, quality of life. Similarly, if a patient has pre-existing dementia also, you can go ahead with thrombolysis with class of recommendation 2B. Illicit drug use. Sometimes patient may be using drug like cocaine, and in that context, patient may have acute ischemic stroke. In that case, also you can go ahead with IB thrombolysis. The recommendation is class 2A. Stroke mimics. So lastly, sometimes there may be some stroke mimics, and in case of stroke mimics, the risk of symptomatic intracranial hemorrhage is quite low. So in those patients also, you can go away with thrombolysis, and you should not delay to find out whether that is a stroke or it is another diagnosis, because as I have mentioned earlier, the time is very important. Time is brain, and urgency is very important. So you have to go ahead with you can go ahead with thrombolysis before pursuing additional diagnosis studies. The class of recommendation is 2A. The stroke mimics may be torus paresis, migraine, multiple sclerosis. Sometimes malingering can also be a stroke mimic. So if you want to know more about this recommendation, the indication and contraindication, you can go to this AHA guidelines. This is the 2019 update, and it is available freely in the net. So lastly, thank you for your kind attention.
Yes, Dr. Krishna, thank you very much for your comprehensive review on indication and contraindication of thrombolysis. And as I conclude from your speech that as far as possible, thrombolysis should be given. Uh, Unless there are very strict contraindication to for thrombolysis like hemorrhage and active bleeding. Anyway, so there are a few questions. I'll ask Dr. Uh, Bikram to take over and then direct the questions to respective speakers, please. Dr. Bikram. Dr. Bikram,
Yes, sir.
ये डॉक्टर विक्रम का
can you
प्रॉब्लम आ
take
ही
over?
रहा है बार बार.
I am not able to. Sorry, can you hear me?
Yeah.
Yeah.
I can also hear all of you, but somehow it looks like my camera is not working now.
Okay. What you can do is you can you click on the questions? There are a few interesting questions, and then direct the questions to the respective speakers.
Okay.
I think there's one question that I'll read it out for you. One of the doctors, I think Dr. Pankaj, has said, asked a question whether the window period is 4.5 hours. What happens if the patient comes after 4.5 hours? What to do? So, Dr. Dipesh, can you say something on that? Dr.
Hello.
Dipesh?
Okay. I am
Yes.
audible. Yes. So that was a very good question, sir. And if the patient comes within 4.5 hours, we do a thrombolytic
We
therapy.
are not able
That is
to hear the pace.
okay. Hello. Hello. Can you hear us? Hello.
Yes. Go
Hello.
ahead.
Can you
Yeah.
can you hear us?
Go ahead, Dr.
Yes. Can you hear me, sir?
Yes, I can hear you.
Okay.
Go ahead and answer the question.
Okay. Generally, if there is the patient comes within 4.5 hours, the trial has told that the therapy is very effectively. But nowadays,
Can you hear the
the
pace?
treatment, yes, sir.
I don't think
Yes, go ahead.
The treatment is not associated with the time these days. What they have thought is the imaging modality. What imaging modality they this do a CT perfusion, MRI perfusion, see whether there is a salvageable tissue or not. There are study done such as extent study, ECAS4 study, which has shown the benefit of thrombolysis even up to 9 hours. So by doing a imaging modality, if there is a salvageable tissue that can be preserved with your thrombolytic therapy, before 4.5 hours it's good. However, we do a coronary angiography in between time to see whether the major artery, a large artery, is occluded or not, to see whether it's the thrombectomy, mechanical thrombectomy may be required or not, sir.
Yes. Yes, having said that, Dr. Divesh, and of course, the earlier is the better, isn't it? The
Yes, sir.
earlier thrombolysis you do, the better
uh,
outcome you get.
yes, yes.
Yes. Dr. Bikram, Dr. Bikram,
So Dr. Vikram, are you audible?
are you, Dr. Bikram, can you hear me?
Yes, sir, I can hear you.
Okay.
Yeah.
Dr. Bikram, yes, please, can you
Uh,
read the
I think
questions and direct them to the respective speakers?
Hmm. There's one another question that is
I
interesting question
cannot
over
hear you
there.
properly, sir.
So
Dr. Bikram
Okay,
can
can you
speak
look at the
now.
question?
Dr. Bikram can speak, see the questions and speak, I think.
Okay.
Yeah, we can hear you.
Something is wrong with my net.
there's a
We can
question.
hear
Okay,
you.
so
There's a
there are.
question
Do you
by
want me to ask
Digvijay.
questions?
Yeah.
Yeah.
Can you see the questions?
Okay, there is one question
Okay,
by
I'll read
Dr.
them out.
Proswell,
Yeah, yeah.
and to one of us, it says, could you please elaborate something in the management about role of antiplatelets and statins, and is there any role of giving loading dose as we do for myocardial infarction?
I think Dr. Bikram, you can answer that. I think we are
Yeah.
actually talking about
Dr.
IV
Bikram, you have
thrombolysis
the question.
today. You can say on that, I think.
Yes. So if the patient is eligible for thrombolysis, then that patient should not be treated with antiplatelets or anticoagulants until it's at least 24 hours post thrombolysis. And depending upon the other indications, patient might be treated with combination antiplatelets or single antiplatelet, but antiplatelets are not indicated in patients who have received thrombolysis in past 24 hours unless there are other compelling indications like acute myocardial infarction with stenting, in which case giving antiplatelets is justified even after receiving TPA in the last 24 hours.
Yes, I think Dr. Bikram, you also, I think there's a query on, is there a role of loading antiplatelets before giving thrombolytic therapy?
No, there is no role of antiplatelets in acute ischemic stroke in patients who are
Yes,
eligible
yes,
for thrombolysis.
yes. Uh, yes, and Dr. Bikram, I think there are other questions. Can you handle them? Can you can you read them out, or shall I read them out? There's a question to Dr. Krishna saying that
Yes.
if the patient has atrial fibrillation with a clot in the left atrium versus it says, is it not beneficial to do thrombolysis in patients with atrial fibrillation who are likely to have left atrial clot in comparison to stroke secondary to last vessel thrombus? So he's, I think, trying to know the benefit of LA clot with stroke versus stroke because of large vessel thrombus.
I think
Dr.
I have
Krishna?
already mentioned that if there is a clot also,
Yes.
we can go ahead with thrombolysis. If it is a major acute ischemic stroke or the stroke is going to cause a lot of disability, if it is a mild stroke, maybe the role of thrombolysis is uncertain. Uh, in if the patient has thrombus and if it is a large stroke, I think it is better to go ahead with thrombolysis.
Yes, I think Dr. Krishna, what you meant was it doesn't matter whether the stroke is from LA clot, source is LA clot, or whether the source is the carotid. We have to thrombolyze the patient, and
Yeah,
the contraindication is only if there is the contraindication you mentioned, isn't it?
yeah.
It doesn't matter whether the source of thrombus, source of ischemic stroke is from LA clot or a large vessel thrombus in the carotid.
I think somebody has asked one question whether there is benefit of thrombolysis in cardioembolic stroke. So we do thrombolysis in cardioembolic stroke also, and in cardioembolic stroke sometimes the thrombolysis works uh, better than in case of atherothrombotic stroke also.
Yes, because of the cloth structure.
Vikram, the other question.
There's a question from Dr. Digvijay Kumar.
There is one interesting question in by Professor Ranamal Piryani, and
Mhm.
it's about in a workup of stroke in workup of acute stroke in young patients with no known risk factors. Nowadays, we can keep COVID-19 in mind as the cause of stroke. What could likely be intervention in such cases? So, though Nepal is at this point in time is among low risk COVID-19 affected countries, but we don't know how the situation will unfold in days to come. So this is a very interesting question. I think I
Yes.
should answer this question.
Yeah, sure.
Any,
Yes, yes.
yeah. So currently, we do not know what actually causes stroke in patients with COVID-19 because there has been a lot of thromboembolic phenomena in COVID-19 patients. A thrombotic or embolic cause of stroke is likely, but um, another possibility is presence of vasculitis of intracranial vessels because of the viral infection itself. And because we are not 100% sure which of these pathophysiological mechanism is responsible in the patient, it may not be safe to thrombolyze patients at present unless unless the
Pathophysiology.
actual pathophysiology is known in the patient. So the current recommendation is that we should not be thrombolizing patients who develop stroke and at the same time have CNS infections. So CNS infections cause vasculitis and that is contraindicated. Thrombolysis is contraindicated in patients who have vasculitis. If the
Mhm.
predominant mechanism of stroke in COVID-19 is thought to is later found out to be thromboembolic phenomena, then in that case, giving TPA might be reasonable. But at present, because we don't know for 100% sure what actually is causing stroke in COVID-19, it is um, um, it's not recommended to thrombolyze patients with COVID-19.
I'd like to say something. I had attended one seminar from India recently, and Dr. Subhas Kaul, I think is a very renowned thrombolysis expert in India. He said that, as Dr. Bikram said, uh, ischemic stroke can occur in COVID patients, and what the management of ischemic stroke in COVID patients is same as those done in other patients. It is not different. Though we know that COVID-19 is a new disease and we have a lot to learn about that. So I think we are not uh, still very much not sure about that.
Yes. Uh,
Okay. Uh,
if it is an if a COVID patient develops stroke, if it is an associated phenomenon, when it develops stroke because of some other reason, then this I think the indication of thrombolysis is quite clear. But as you said, uh, if the stroke is because of COVID comorbidity and COVID has some as a contribution in developing this stroke, then I think we should go and thrombolyze the patient. Anyway, so can I go on another question? There's another
I think
question.
Another
Dr.
question.
Bikram,
I
I
am
think there is
online,
one
sir.
question.
I'm online,
Oh,
sir. My camera is
yeah.
not working, unfortunately,
Okay.
but
Okay.
I can
Okay.
listen to all of you.
Okay. Okay.
Something is
Dr.
wrong with my
Bikram,
camera.
I think you can say on this. Is there any role of mechanical thrombectomy along with thrombolysis?
Yes. So
There is one
currently,
question there, so I think.
yeah. Is there any role
Yeah.
of mechanical thrombectomy along with thrombolysis?
Yeah.
Yes.
Yeah, yeah.
So
Yes.
yes,
the current recommendation is to, if the patient is eligible for thrombolysis
Thrombolytic therapy.
and is also a candidate for mechanical thrombectomy, the patient should receive
Thrombolytic.
thrombolysis as well as mechanical thrombectomy. So
Yes.
current recommendation is to go ahead with thrombolysis as well as mechanical thrombectomy. So
Yes.
there are currently some trials that are looking into whether doing mechanical thrombectomy without thrombolysis is beneficial in patients who also are eligible for thrombolysis. And until the result of that trial is out, we should all be, the current standard of care is to give TPA if that is indicated in addition to mechanical thrombectomy. So
At the same time.
we should
Thank
be
you.
doing both of those in patients who are eligible.
Yes.
I think another question, I think that also, I think Dr. Bikram can answer. Can anyone shed some light about intra-arterial thrombolysis?
So yeah, thank you, Krishna. Intra-arterial thrombolysis is not practiced nowadays. So in some cases in which mechanical thrombectomy is done, and sometimes the clot can dislodge and go and lodge into distal arterial tree. So in that case, giving intra-arterial TPA, a very small amount of intra-arterial TPA at the time of mechanical thrombectomy can lyse those clots. But currently, because there are more effective treatments with current mechanical thrombectomy devices, intra-arterial thrombolysis is not recommended and is not done.
So there is a question, I guess, from Dr. Digvijay
There
Kumar.
is one interesting question.
Yeah.
Can we thrombolyze in lacunar infarct? And what
yes.
if there is reinfarction after 3 months
3 months.
of thrombolysis? Can we re-thrombolyze? So, Krishna?
I think lacunar stroke also we can thrombolyze it. We can, if the CT is normal, we can go ahead with thrombolysis. That means if there is a lacunar infarct also we can thrombolyze. Another is if the stroke occurs after 3 months of ischemic stroke. I said that within 3 months we don't thrombolyze because there may be more risks. But after 3 months we can go ahead with thrombolysis if other indications are met, if the eligible criteria are met, or the eligible criteria.
Yeah, exactly. So, clinically, we don't differentiate whether it is large vessel or small vessel. So, if it is a stroke and CT is normal and the patient is eligible, we should thrombolyze whether or not that is lacunar or not. And if the
Yes.
stroke is after 3 months of, if it is a reinfarction after 3 months, then we should be thrombolizing that patient if the patient meets other eligibility criteria. So there
I
is,
think there's another question
yeah,
for
to
Krishna.
Krishna.
I think that's
Yeah.
the question. Can you read that? It says, what if there are multiple blockade with carotid artery stenosis? I suppose he means that if the patient has ischemic stroke with multiple blockades of carotid artery.
We can go ahead with thrombolysis. There is no
Yes.
disadvantage of that because we don't see about the carotid artery and others while doing IV thrombolysis. these all imaging, CT angiography and other we do, and plan for mechanical, while planning for mechanical thrombectomy. For IV thrombolysis, only if we are doing IV thrombolysis, only CT angiography may not be necessary also.
Yeah, exactly.
Okay.
Yes,
And
there is different,
sometimes if there is
different.
multiple blockages, and if that is not eligible for, even if the patient has large vessel occlusions, but patient has carotid artery anatomy which does not allow you to do mechanical thrombectomy, then in those cases the only thing that we can do is giving thrombolysis only, and that only if it's within the appropriate time window and if there are other eligibility criteria. So if the anatomy is not favorable, then mechanical interventions may not be, could not be done, cannot be done. That is one a drawback of mechanical thrombectomy.
So I think there is one interesting question. If patient is TIA, transient ischemic attack, and thrombolysis is given, what happens?
There's another question like this.
Okay,
I
Dipesh.
think this I will finish this first.
Okay.
I
Okay.
think this is like if you give thrombolysis for stroke mimic, nothing happens. So if it is TIA, it improves. If you give thrombolysis, I think it will not cause harm. You don't wait for 24 hours to see whether the patient improves or not. When the
Yes,
patient comes to you,
exactly.
you judge at that moment and decide whether to give thrombolysis or not. At that time, you have
Exactly.
to judge what is the deficit of the patient and go ahead with thrombolysis.
Yes. So
Exactly.
when we
So
have
the
any
middle
patient with
actually
symptoms of
normalize
stroke,
But
yes.
as much as
So
possible. Anyway.
when the patient
yeah. So when the
tries
patient, when we get any patient with acute symptoms of acute stroke, we do not wait and see whether that is TIA or not. So if there are disabling deficits, and if the
yes,
patient has other qualifies qualifies for thrombolysis based on inclusion and exclusion criteria, then that patient should be treated with thrombolysis.
disabling transient ischemic attack
There is
or
another
NIH.
interesting question: can we thrombolyze in stroke secondary to cerebral sinus thrombosis?
No, no.
Hmm.
Yeah. So
Sometimes,
yes,
I
yeah,
think
Krishna.
Dr. Vikram will answer.
Yeah. So ischemic strokes due to cerebral sinus thrombosis, they are not like acute ischemic stroke because of embolic or thrombotic arterial thrombotic phenomena. They are usually slowly developing. So thrombolysis intravenous, I mean, mechanical intervention to dissolve the clot by using a recombinant tissue plasminogen activator can be done. Local thrombolysis can be done, but intravenous systemic thrombolysis is not done in cerebral sinus thrombosis. There is an interesting question, sir. Is there any role of neuroprotective agents? This is very interesting question. Can anyone answer? I have a good answer for that.
Dr. Deepesh?
Okay. I think neuroprotective has a very less benefit over its cost.
We can't
So I
hear
think
the pace.
neuroprotective agent has a
I can't hear the pace.
hello. Can you hear me?
I think we can hear.
You can hear me.
Okay.
Yeah, go
Maybe
ahead.
Yeah.
okay.
Neuroprotective agent has a less rule compared to its cost. Maybe it's working 5 to 15% only. So I think it's still in study, the CDP cooling. Otherwise, other neuroprotective methods such as lowering the body temperature in thrombolysis is not that much effective as study. But however, hyperglycemia, over hypoglycemia, these are also not good for the patient in context. And fever has to be controlled. It also increase the neurotoxicity. So apart from drugs, other medicine and this maintenance of vital is important, I guess, for as a neuroprotective. Can you hear me, Dr. Bikram? Can you hear me, Dr. Krishna?
Yeah, yeah.
Yeah.
Dr. Bikram?
Yes, Krishna, I can hear you.
Yeah,
I
I
could not
think
hear Dipesh.
Add on.
I think you can give your view on that, Dr. Bikram.
Yes, so currently there is no evidence that using neuroprotective agent is useful in acute ischemic stroke. So giving neuroprotective agent is not recommended in any form of acute ischemic stroke. There is a trial that is that has recently stopped recruiting, that has completed recruiting patients, in which patients with large vessel occlusion are treated in standard manner, and one group of patient will receive neuroprotective agent, and the result of that trial is expected to be out by the end of this year. So we will know if giving neuroprotective agent will be helpful or not based on that trial. But for until that the result of that trial is out, we should not be using any neuroprotective agent in patients who are either treated with TPA or with mechanical thrombectomy.
I think this question is for the Dr. DPS. Cost of thrombolysis.
Cost of thrombolysis.
Post.
Cost of thrombolysis.
What is the
Okay.
cost of thrombolytic
Yes.
agent and the overall cost?
Yes. Okay. It's a bit costly. We get a vial of 50 mg dry powder, and we have to dissolve it. It costs about 67,000 per vial. So I think for a patient, we give a dose of 0.9 mg per kg. We require about 60 to 70 kg. We require one and a half vial. That is 50 mg vial and 20 mg vial. So maybe the patient cost about 75,000 to 90,000 according to its weight. So it's bit costly. Though it's costly, its benefit outweighs its cost and its side effect. So I think it's worth giving a patient to this therapy, because later in his life, the amount he is going to spend on the his rehabilitation and his financial working capacity, occupational, everything matters in this patient. So I think cost of thrombolysis, though costly, is can be given to the patient provided they are making understood about this therapy.
Yes, I think in this, as far as cost is concerned, NAN, Nepalese Academy of Neurology, is working with the government to get some subsidy for ischemic stroke. So if that comes through, then that will help a lot to the patients. I think we're working on, like, if the patient has ischemic stroke and needs thrombolysis, then government may be giving around some substantial subsidy, maybe up to 1 lakh. So we are still working on it.
There
So
is
that might
one
cost.
question, I think
I
I'll
think
answer that.
Yeah, I think
that's the
your
next
question.
If a patient already is on warfarin due to
yes, warfarin therapy for a
is
year.
on
Can
warfarin due to
Yeah, if the
atrial
patient is on
fibrillation,
warfarin
now
and has
develops
stroke,
ischemic
what do you
stroke,
do?
can we thrombolyze this patient? Yeah,
I think.
yeah. I already spoke about this, I think. So if a patient is on warfarin, you have to do PT INR, and if the INR is less than 1.7 or a PT is less than 15 seconds, then you can go ahead with thrombolysis, but the recommendation is class 2B only.
Yeah. And then, Dr. Krishna, you can also take up that question. He says, is there a benefit of heparin after 4.5 hours in stroke? So that also you've already seen.
Is there therapeutic benefit of heparin after 4.5 hours in stroke? In stroke, the role of
no,
heparin is
no,
only in case of cardioembolic stroke. And
36.
at this moment, we are not talking about that. If there is cardioembolic stroke, we have to look at the size of stroke. And if the size of stroke is less than one third of the MCA, start anticoagulants after 48 hours. But if the stroke is more than one third of the MCA territory, maybe we have to wait for around 2 weeks to give thrombolysis. Dr. Bikram, will you like to add something, or
For heparin,
heparin anticoagulation in ischemic stroke?
No, there is no evidence that using anticoagulation immediately after stroke is useful. So unless the patient has other indications for anticoagulation therapy, prescription giving heparin is not indicated, even after it's more than 4.5 hours, unless the stroke is small and patient has other indications of therapeutic heparinization, like a large LA clot or a floating clot in the carotid artery. So these are the only indications. And even in those cases, therapeutic anticoagulation should not be done in patients who have large strokes, like patients who have stroke more than one third of MCA territory or more than half of PCA territory. I want to answer one question. Is it beneficial to thrombolyze a new onset lacunar stroke presenting as pure hemiplegia, keeping in mind that the pathogenesis behind lacunar infarction being lipohyalinolysis? So when the patient presents with pure hemiplegia, if a patient presents with any
Hello.
thrombolysis is indicated in all patients who present with symptoms of stroke and have any eligibility criteria. So it does not matter whether that is cardioembolic, whether that is atherothrombotic, or whether that is lacunar. So we do not care about pathophysiological mechanisms when we are confronting a patient with acute ischemic stroke. We just want to know whether the patient has acute ischemic stroke or not, whether the patient is disabled by his deficits or not, and if it is clinically suggestive of acute ischemic stroke, and if the deficit is disabling and there are no contraindications in the patient, contraindications or relative contraindications in the patient, then that patient should be thrombolyzed. So we think of pathophysiological mechanisms only after thrombolysis or mechanical thrombectomy is done, or only when the patient is not eligible for any of these interventions.
There's a question. Says, what does study says
There
about
are
thrombolytic
so
patient with
many
queries?
beautiful questions.
Yeah.
So
Can I
This
take
one
a
question, I think I have
Yeah.
already answered. So I'll just say it once again. Uh, there is one question like, if a patient is getting aspirin and the patient develops acute ischemic stroke, what should you do? I already said that in those cases, you can go ahead with thrombolysis. There is a class of recommendation 1.
Okay. There is a question I would like to clear that if the ischemic stroke beyond 6 hours with a large penumbra. So when there is a imaging modality facilitating of seeing the large penumbra, the imaging through imaging modality,
there is one.
even
Okay,
even
sorry.
after 6 hours, we can do a thrombolysis therapy and
I
do a
think
CT
it's
angio.
better to
Yeah.
go for
Uh,
mechanical thrombectomy in those cases. And usually
yeah.
after
Yeah.
4.5 hours, we don't usually try to go with IV
Yes.
thrombolysis. We try to go with other forms of therapy like mechanical thrombectomy. So I think mechanical thrombectomy will be a very good option in those cases.
Okay.
Yes. Mechanical thrombectomy has a large window period. So I think they say
24
you
hours.
can go even beyond. No?
So
Dr.
in some
Bikram, I
centers,
think, can you tell something about mechanical thrombectomy just for the audience sake? Mechanical thrombectomy, just one short.
yeah, mechanical thrombectomy. So all patients who present with acute symptoms of acute ischemic stroke should be evaluated with a vascular imaging with and the vascular imaging that's readily available in most centers in our country are CT angiogram of head and neck. So all patients, regardless of whether they are receiving TPA or not, all patients with acute ischemic stroke should also be receiving imaging of the vessels of the brain as well as the neck, CT angio of head and neck. And if they are found to have large vessel occlusion, and there are no contraindications, then these patients should be taken for mechanical thrombectomy, provided they are within 24 hours. They meet eligibility criteria and they are within 24 hours of symptom onset. So all patients who have large vessel occlusion in their CT angiogram, they should be taken for mechanical thrombectomy, regardless of whether they improve. Regardless of, we should not be waiting. If the patient has received TPA and has large vessel occlusion, we should not be waiting to see if the patient improves or not. So that will cause delay in treatment, and that can impact outcome. So if the, regardless of whether the patient receives TPA or not, then that patient should have vascular imaging done, and if there is large vessel occlusion, that patient should be taken for mechanical thrombectomy. And currently, until 2 years ago, the time window for mechanical thrombectomy was up to 6 hours, and now the time window for mechanical thrombectomy has been extended up to 24 hours. So after 6 hours of symptom onset, patient should be should undergo advanced imaging with CT perfusion or magnetic resonance angiogram, MRI, magnetic resonance studies to see if they are eligible or not.
So, Dr. Krishna, I think there is a question for you. If the patient you have thrombolized the patient, and the patient develops re-stroke after 12 hours of first thrombolysis, what do you do? Do we
I,
re-thrombolize the patient?
I think there is a no clear guideline for this. Like if a patient develops ischemic stroke, we have thrombolized the patient. And as I said, if the patient develops re-stroke, I said that if the patient has ischemic stroke within the last 3 months, it is better not to thrombolize the patient. It may cause more harm. So I think if a patient develops second stroke within 12 hours, I think it's better not to thrombolize the patient.
Yeah,
Can the patient go
exactly.
for mechanical thrombectomy then?
Yeah. I think it can be considered in those
Yeah,
patients.
within
Angiogram
12
to
hours.
be
Mechanical thrombectomy
thrombolize
can be considered.
it.
Okay. The,
So there's another question here. When to resume warfarin therapy in already patient already taking warfarin with AF and who develop ischemic stroke?
if the INR is in the therapeutic range or not. If the patient has a INR under therapeutic range, then we make a INR to the level. If the patient doesn't have even the patient has a INR in the level and the patient has a stroke, then we will should add upon another antiplatelets, I guess. That is the
Yes,
recommendation.
so what it meant
I
was
think it is first we have to stop the anticoagulants for the time being,
Correct.
and after that you should look at the size of the stroke. So
Hmm.
if the
Hmm.
stroke is of small size, we can start after 48 hours, and we should increase the dose if it is the subtherapeutic. If it is large stroke, even if there is atrial fibrillation, then we should wait for 2 weeks if there is a large stroke. There is one interesting question, I think. I
Yes.
don't know the. What about thrombolysis in suspected spinal cord infarction within time window? I think Dr. Bikram, can you answer?
Yes, if you
I
have
don't
strong
have idea
suspicion,
about this.
if you have strong suspicion that patient has acute ischemic event of the spinal cord and meets other eligibility criteria, then that patient should be thrombolized. If the patient has
so overall.
clear cut
Mhm.
evidence of anterior spinal artery syndrome and has risk factors of stroke, then if it resembles, if it's sudden onset paraplegia with preserved dorsal column signs and involvement of anterior segment of the clear cut evidence of involvement of the anterior segment, and if it's sudden onset, then it's highly likely that it's a ischemic event, and that patient should also receive mechanical thrombectomy. I mean, that patient should also receive TPA, should also be thrombolized, like exactly like other
So the overall
ischemic stroke patients.
is the same as the ischemic attack, isn't it?
Yeah.
I think this question, I think Dr. Deepesh can answer. It is very
Yeah.
hard to determine the exact time period when symptoms started. In those situations, how we should proceed?
Yes, there's a study, a wake-up study that has been done where the patient doesn't know. The patient wakes up in the morning. The patient finds himself or herself weakness, and the patient doesn't know what the time. Or the patient party doesn't know what the time. The time is taken the last when the patient was okay. So, with the,
Dipesh, can you put your mic towards your mouth
okay,
a little?
okay. So, can you hear me, sir? Okay.
Yeah, okay.
So, so what we do is, if the patient wake up time and the symptoms is less than 4.5, we go for the general thrombolytic therapy. If not, then we do the imaging technique, that is CT perfusion, MRI perfusion, where we can find out at what time. Just MRI flare, example MRI flare. From the flare, we can find out whether it is more than 4.5 hours or less. So we can know about by the imaging modality what time, or is there a salvageable tissue or penumbra tissue or not. Then we do a thrombolytic therapy. There was again, I would like to quote, there was a meta-analysis done by Extend, ICAS4 and EPITHEP, which was based on imaging modality, and there was the patient treated at the time for 4.5 hours to 9 hours, and that showed a very functional good outcome. But we are not that specialized setup, so with, I think we should stick on to less than 4.5 hours, and further we should refer or do a intense imaging for the treatment.
I think in this case, what he wants to ask is, you should take from the time when the patient was last known to be
Okay.
normal.
Yes.
Okay, so
Oh,
since that time, you have to find out how many hours since that time the patient has developed symptoms.
But these days
I think there
it's
was a slide,
not only the time,
Doctor.
but also the preservable tissue, the penumbra tissue. The tissue study should be done for the proper thrombolytic therapy as well.
I think you had a slide on DWI and flare
Yeah. Yes, sir. Yes.
pertaining to this issue, wasn't there?
Yes, sir. Yes, sir.
So can you help me with that?
Yes, sir. Pardon, sir. So
Sir, I
basically,
think
There was
I'll
a,
answer that.
okay.
yeah, yeah.
That is that wake up trial that is mentioned. That is, if the patient wakes up with stroke, then in that case you don't know when the patient has a stroke. He may have 1 2 hours before waking up or many hours before waking up. In that case, you do a MRI and you do FLAIR and DWI image. So if
Yes.
the DWI images shows some finding or the flare is negative, that means that the stroke is less than 4.5 hours old. In this case, you can go ahead with thrombolysis and the class of recommendation is 2A.
Okay.
Yes.
So that's another help. Yes.
Hmm.
Uh, example therapy untreated private. Yes. Okay. I think can
I
you read
think we
this
have
question?
answered most of the questions which was
Yes.
kept.
Uh,
Dr. Bikram, do you see
do you
any
want
other
to
questions
say something?
which have?
Yeah, I think we have answered many of those questions. So I think we have spent good amount of time answering with the questions and answers. So, Ravindra sir, do you think we should be addressing
Yeah.
few more
Yeah.
questions?
I think we should close down because it's nearly 2 hours now.
Yeah,
I think there was a very interesting interaction, a lot of good questions, and the speakers were also very good in
yeah,
putting up their ideas about ischemic stroke. And I hope now, by you know, at the end of this lecture, I hope the doctors, the internists are more confident now in starting thrombolytic therapy in ischemic stroke.
yeah,
So
exactly.
yeah. So shall we then close the session? Dr.
Yeah,
Bikram, would you like to say something? Thank the speakers and give a vote of thanks.
I think Dr.
yeah.
Bikram can say something and end of the session, I think.
Yes, thank you, sir.
Thank
Thank you,
you.
Ravindra sir. I would like to thank our National Neurological Association and Ravindra sir for inviting me into this very interactive and very useful session. I am pretty sure that this session would enable many of us to gain confidence in evaluating and managing patients with acute ischemic stroke with respect to intravenous thrombolysis. And we should always remember that all patients with acute ischemic stroke are potentially treatable with intravenous thrombolysis and mechanical thrombectomy, and we should be evaluating patients as early as possible in order not to waste time, because with time many neurons are lost and the chances of good recovery also decreases with time. So Dr. was very elaborative on the steps of management, the indication, the dose and the duration of treatment, and what are the complications, how we should be managing those, how we should recognize whether the patient has blade inside their brain or not. So it was a wonderful presentation by Dr.
Thank you, Rai.
Krishna's was very elaborate in talking about the actual indications and contraindications while we are thinking about thrombolysis. And the question and answer session was wonderful. We got a lot of questions. But we felt that we have been able to provide answer to many of the questions that have been asked. And I would like to thank both the speakers for their wonderful presentation. I would like to thank Ravindra sir again for making this possible. And I would like to thank Synergy Corporations for helping us arrange this talk program. And we would expect to undertake similar programs in the future too. So with this, with the permission of Ravindra sir, I would like to end this session. Thank you, everyone. Thank you, sir.
Thank you.
Thank you.
Thank you,
Thank you.
sir. Thank you.
The center, please take over. Thank you, everybody. We would like to end the session.
Thank you, sir. Thank you, everybody. We'll end the session.
मात्रै छ त। के तिम्रो मात्रै छ?
होइन, अरू पनि हुन्छ, तपाईँहरू म मात्र होइन। ल, बाई बाई, राखिदिनुहोस्।
खोइ त यहाँ कहाँ हिँड्यो?
स्टप ल।
हेलो विवेक जी।